Dr. Travis Liddell, and I'll be discussing an ACL reconstruction using a hamstring autograft. In the normal knee, there are four major ligamentous stabilizers to the knee, the ACL being one of the primary stabilizers. Here you see a diagram depicting a knee with a torn ACL. You can see the torn ACL overlying a normal posterior cruciate ligament, or PCL, behind it. Diagnosis of a torn ACL is typically made on clinical exam, but then confirmed with an MRI. The MRI image on the left here indicates a normal ACL with its fibers still intact. On the right, you can see a loss of these dark fibers indicating a complete tear of the ACL. ACL reconstruction can usually be performed using small incisions and instruments to minimize the invasiveness of the procedure. Using these instruments, we can reconstruct the torn ACL, giving the patient a completely new ligament that provides the missing stability and return to activity. I'm actually going to show you images of an ACL reconstruction as viewed through our arthroscopic camera. We first get inside the knee, we take a look at the cartilage underneath the kneecap as well as the groove that the kneecap slides in. And we want to look at the medial meniscus and the compartment containing cartilage inside the knee. We're going to inspect our ACL and see if that's torn as the MRI is indicated. Here you can see the ACL is completely torn away from its attachment, which should attach here on this wall of bone inside the notch at the end of the thigh bone. We also look at the lateral meniscus, which is the meniscus on the outside of the knee, and the cartilage surface there. Now we're going to clean away the portion of the ACL that's torn, exposing the footprint where we want our new ACL reconstruction to attach and insert through. This is the attachment of the ACL on the shin bone called the tibia. We're going to remove this area as well and clean off this surface again to drill our tunnels in the correct positions in the knee. We're removing a small ledge of bone that can sometimes block the proper footprint to ensure that we put this ACL in the right position. I want to be careful to remove all the scar tissue and get clean surfaces, as well as removing the remnants of the old ACL, as this can scar and cause a lack of motion in the patient postoperatively if not done completely. We're positioning one of our drill guides to put this graft. We're going to drill a tunnel on the end of the thigh bone called the femur. You can see our guide pin going in. We're going to pull that guide pin through and take a look through one of our other cannula portals. This is to really ensure that we've got that drill point all the way in the back of the knee where it's supposed to be. Now we're going to drill over this guide pin using some cannulated drill bits. First we do a smaller drill hole. We do a slightly larger drill hole that's actually going to be sized appropriately according to the size of our graft. The graft that we use for this is hamstrings that are harvested from the back of the patient's knee. Here you can see the drill guide still remaining within the hole, with the hole being drilled over that. Now we'll pull a special suture through the tunnel and inspect the tunnel. Make sure there's been no breach of the wall in the back. Once this has been performed, we'll drill our tunnel in our shin bone called the tibia. We want this to come right through the footprint of that native ACL that we removed earlier in the procedure. Take the knee through a range of motion also to ensure that there won't be any impingement, which could cause a lack of full extension in the knee if we're too far to the front of the knee with our graft tunnel here. Now we drill our tunnel and pull our suture down through that will be used to shuttle our graft. I'm going to use these sutures to shuttle our graft through our tibial and femoral tunnels. Once the graft is securely docked, it's going to be fixed at both ends. This will hold the graft in place while it heals. I'm going to test the graft with a probe to make sure it's nice and tight, that there's no laxity in that graft. And then we'll take that knee through a range of motion to ensure there's no impingement, that the knee gets to full extension and full flexion. There will be no stiffness for this patient postoperatively. After that, the small incisions, which are each about 1 centimeter to 2 centimeters in length, are closed and the patient's knee is placed into a brace. The patient is discharged with crutches, but is allowed to start putting weight on their knee as soon as they feel comfortable with the knee locked in full extension. I usually like my patients to start therapy within a maximum of 5 days after their surgery, And I usually see them back in 10 to 14 days for their suture removal and make sure that they're progressing as expected with physical therapy. Overall, I tell my patients to expect a recovery of 4 to 6 months, with return to jogging at around 4 months and full athletics closer to the 6-month mark.